Good morning, my friends. I am Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia, and we'll continue to talk about myocardial infarction. And as I promised, talk today about drugs. So actually, once again, let's remember, I recall you that this is the same chain, okay? It's starting with metabolic syndrome, then goes to, like Russian matryoshka, metabolic syndrome, then we've got atherosclerosis, then we've got coronary artery disease, then we've got clinical compliance, clinical revealing of this situation, clinical evidence of this situation, angina, stable angina, and then we've got acute coronary syndrome. So actually, drugs for acute coronary syndrome, drugs for acute myocardial infarction, drugs for angina is the same thing. Now, can we say almost the same thing? So treatment is designed to relieve distress, interrupt thrombosis, reverse ischemia, okay? Reverse ischemia, limit infarct size, reduce cardiac workload, and prevent and treat complications. As a myocardial infarction is a medical emergency, outcome is greatly influenced by the rapid diagnosis and treatment. So acute myocardial infarction enters to the noting, to understanding, to the diagnosis of acute coronary syndrome. Treatment occurs simultaneously with drugs, with diagnosis. Treatment includes revascularization with percutaneous coronary interventions, coronary artery bypass grafting, or fibrinolytic therapy, and drug therapy to treat acute coronary syndrome and underlying coronary artery disease. Drugs used depend on the types of situation and include aspirin, clopidogrel or both, prasugrel or ticagrelor are alternatives to clopidogrel in fibrinolytic therapy has not been given. Beta blocker is the king. Glycoprotein 2B3A inhibitor considered for certain patients undergoing percutaneous coronary intervention, so PCI, angioplasty, and high-risk lesions, for example, high thrombus burden, no reflow. A heparin, unfractioned or low molecular weight heparin, or bivalirudin, particularly in STEMI. So STEMI is ST segment elevation myocardial infarction. Patients at high risk of bleeding. Intravenous nitroglycerin unless low risk and complicated myocardial infarction. Fibrinolytics for select patients with STEMI, so ST segment elevation myocardial infarction, when timely PCI is unavailable. Angiotensin converting enzyme inhibitors, so AC inhibitors, or just inhibitors, as early as possible, and statins. Antiplatelet and antithrombotic drugs, which stop clots from forming, are used routinely. Anti-ischemic drugs, for example, beta blockers, intravenous nitroglycerin, are frequently added, particularly when chest pain or hypertension is present. Fibrinolytics should be used for non-contraindicated, if not contraindicated, for STEMI, so elevation myocardial infarction, if primary PCI is not immediately available, but worsen outcome for unstable angina and non-ST segment elevation myocardial infarction. So we don't use fibrinolytics in unstable angina or non-STEMI. In STEMI, with VC elevation, we do our fibrinolytics. And after this, we can reflect, make some reflections. Where is PCI? Where is CAT lab? So chest pain can be treated with nitroglycerin or sometimes morphine. Nitroglycerin is preferable to morphine, which should be used judiciously. For example, if a patient has a contraindication to nitroglycerin or is in pain despite nitroglycerin therapy. Nitroglycerin is initially given sublingually, followed by continuous intravenous drip if needed. Morphine 2 to 4 milligrams repeated every 15 minutes as needed is highly effective, but can depress respiration, can reduce myocardial contractility, and is a potent venous vasodilator. Yes, there is a large retrospective trial showed that morphine may increase mortality in patients with acute myocardial infarction. But let's be honest, if it's possible to use morphine, let's do this, because shock is without morphine is very possible. Hypertension and bradycardia secondary to morphine can usually be overcome by prompt elevation of the lower extremities. Blood pressure is normal or slightly elevated in most patients or on arrival at the emergency department. Blood pressure gradually falls over the next several hours. Continued hypertension requires treatment with antihypertensives, preferably intravenous nitroglycerin, to lower blood pressure and reduce cardiac workload. Severe hypertension or other signs of shock are ominous and must be triggered aggressively with intravenous fluids and sometimes vasopressors. This was introduction. Let's talk now about antiplatelet drugs. Aspirin, clopidogrel, prasugrel, ticagrelor, and glycoprotein 2B3A inhibitors are examples of antiplatelet drugs. All patients are given aspirin 160 to 325 milligrams non-enteric-coated if non-contraindicated. For example, life-threatening active bleeding. At presentation and 81 in the United States, milligram once a day, identically thereafter. Chewing the first dose before swallowing quickens absorption. Aspirin reduces short and long-term mortality risk. Yes, if aspirin cannot be taken, clopidogrel 75 mg orally once a day or the ticlopidine 250 mg orally twice a day may be used. Clopidogrel has largely replaced famous ticlopidine for routine use because neutropenia is a risk with ticlopidine and the white blood cell count must be monitored regularly. Patients not undergoing revascularization, for example, patients with acute coronary syndrome in whom intervention is not possible or recommended, are given both aspirin and clopidogrel for at least 12 months. In general, the concern with dosage and duration of antiplatelet drugs is to balance the decreased risk of coronary thrombosis with the increased risk of bleeding. Patients undergoing revascularization is patients undergoing PCI. A loading dose of clopidogrel 300 to 600 mg orally once, prasugrel 60 mg orally once, or ticagrelor 180 mg orally once improves outcomes. Some clinicians give a glycoprotein 2B3A inhibitor during PCI to all high-risk patients, for example, those with markedly elevated cardiac markers, a TIMI risk score more than 40, persistent symptoms despite adequate drug therapy, with large thrombus burden. The glycoprotein 2B3A inhibitor is continued for 6 to 24 hours, and angiography is done before the infusion period is over. So glycoprotein 2B3A inhibitors are not recommended for patients receiving fibrinolytics. Abciximab, tirofiban, and eptifibadid appear to have equivalent efficacy, and the choice of drug should depend on other factors, for example, cost, availability, familiarity. For patients receiving a stent for revascularization, aspirin is continued indentively. Clopidogrel 75 mg orally once a day, prasugrel 10 mg orally once a day, or ticagrelor 90 mg orally twice a day should be used for at least 1 month in patients with a bar metal stent. Patients with a drug-eluting stent have a prolonged risk of thrombosis and may benefit from 6 to 12 months of clopidogrel or prasugrel or ticagrelor treatment. The recommended treatment duration is still actually unclear. Anticoagulants. Enter a low, either a low molecular weight heparin, unfractioned heparin, or bivalirudin is given routinely to patients with acute coronary syndrome unless contraindicated, for example, by active bleeding or planned use of streptokinase or antistreplase, yes. Choice of agent is somewhat involved. Patients at high risk of systematic emboli also require a long-term therapy with an oral anticoagulant, for example, warfarin, dabigatran, apixaban, rivaroxaban. Conversion to oral anticoagulants should begin 48 hours after symptoms resolution on PCI. Unfractioned heparin is more complicated to use because it requires frequent every 6 hours dosing adjustment to achieve an adequate partial thromboplastin time, APTT, 1.5 to 2 times the control value. In patients undergoing angiography, further dosing adjustment is done to achieve an activated clotting time of 200 to 250 seconds if the patient is treated with glycoprotein 2B3A, and 250 to 300 seconds if a glycoprotein 2B3A inhibitor is not being given. However, if bleeding develops after catheterization, the effects of unfractioned heparin are shorter and can be reversed by promptly stopping the heparin infusion and giving protamine sulfate. Low molecular weight heparin. The low molecular weight heparin have better bioavailability, are given by simple weight-based dose without monitoring APTT and dose titration, and have lower risk of heparin-induced thrombocytopenia. They also may produce an incremental benefit in outcomes relative to unfractioned heparin in patients with acute situation, with acute ischemia, with acute coronary syndrome. Of the low molecular weight heparins, enoxaparin appears to be superior to dalteparin or nadroparin. However, enoxaparin may pose a higher bleeding risk in patients with STEMI who are aged more than 75 years, and its effects are not completely reversible with protamine. Thus, taking all into account, many published guidelines recommended low molecular weight heparin, for example, enoxaparin, over unfractioned heparin in patients with unstable angina or non-STEMI, and in patients less than 75 years aged old with STEMI who are not undergoing PCI. By contrast, unfractioned heparin is recommended when emergency PCI is done, for example, patients with acute STEMI, myocardial infarction, elevation, who proceed to the catheterization laboratory. When CABG is indicated when the next 24 hours, is indicated within the next 24 hours, and when patients are at high risk of bleeding, complications, for example, history of bleeding with the last 6 months, or have creatinine clearance less than 30 milliliter minutes. Ongoing studies should help clarify and choose between low molecular weight heparin and unfractioned heparin. For patients undergoing PCI, post-procedure heparin is no longer recommended unless patients are at high risk of thromboembolic events. For example, patients with large anterior myocardial infarction, low left ventricle thrombus atrial fibrillation because post-procedure ischemic events have decreased with the use of stents and antiplatelet drugs. For patients not undergoing PCI, heparin is continued for 48 hours, or longer if symptoms persist. Yeah, we've got some heparin alternatives. The difficulties with the heparins, including bleeding complications, the possibility of heparin-induced thrombocytopenia, and with infraction heparin, the need for dosing adjustments have led to the search for better anticoagulants. The direct thrombin inhibitors, bivalirudin and argatroban, may have a lower incidence of serious bleeding and improved outcomes, particularly in patients with renal insufficiency. Hirudin, another direct thrombin inhibitor, appears to cause more bleeding than the other drugs. The factor 10A inhibitor fondaparinux reduces mortality and reinfarction in patients with STEMI who undergo PCI without increasing bleeding, but may result in worse outcomes than infraction heparin in patients with STEMI. Although routine use of these alternative anticoagulants is thus most currently recommended, they should be used in place of infraction heparin or low molecular weight heparin in patients with known or suspected history of heparin-induced thrombocytopenia. Bivalirudin is an acceptable anticoagulant for patients undergoing primary PCI who are at high risk of bleeding and is recommended for those with unknown suspected history of heparin-induced thrombocytopenia. For patients with unstable angina or non-STEMI, dose is initial bolus of 0.1 milligram on kilogram intravenous, followed by a drip of 0.25 kilogram an hour. For patients with STEMI, initial dose is 0.75 kilogram intravenous, followed by 1.75 kilogram an hour. About beta blockers. Beta blockers are recommended unless contraindicated. Beta blocker is the king. So contraindication, for example, tachycardia, heart block, hypertension, or asthma. But they're highly recommended for all patients, especially for high-risk patients. Beta blockers reduce heart rate, arterial pressure, and contractility, thereby reducing cardiac workload and oxygen demand. Infarct size largely determines cardiac performance after recovery. Oral beta blockers given within the first few hours improve prognosis by reducing infarct size, recurrence rate, incidence of ventricular fibrillation, and mortality risk. Heart rate and blood pressure must be carefully monitored during treatment with the beta blockers. Dosage is reduced if bradycardia or hypertension develops. Excessive adverse effects may be reversed by infusion of the beta-adrenergic agonist isoproterenol 1 to 5 microgram, 5 to microgram per minute. Nitrates. A short-acting nitrate, nitroglycerin, is used to reduce cardiac workload in selected patients. Nitroglycerin dilates veins, arteries, and arterioles, reducing left ventricle preload and afterload. As a result, oxygen demand is reduced, lessening ischemia. Intravenous nitroglycerin is recommended during the first 24 to 48 hours for patients with heart failure, large anterior myocardial infarction, persistent chest discomfort, or hypertension. Blood pressure should not be reduced to less than 110 to 120 milligram hydrargyrum systolic patients who remain symptomatic, and that blood pressure should have emergency PCI rather than further blood pressure reduction. Okay? Longer use may benefit patients with recurrent chest pain or persistent pulmonary congestion. In high-risk patients, nitroglycerin given in the first few hours reduces infarct size and short-term and possibility long-term mortality risk. Nitroglycerin is not routinely given to low-risk patients with uncomplicated myocardial infarction. About fibrinolytics. Tenecteplase, alteplase, reteplase, streptokinase, and antistreplase. Antistreplase is an isolated plasminogen activator complex. So APSAC is antistreplase. All given intravenous are plasminogen activators. They convert single-chain plasminogen to double-chain plasminogen, which has fibrinolytic activity. They often different characteristics and dosing regimens and are appropriate only for selected patients with STEMI. Treatment and reteplase are recommended most. So tenecteplase and reteplase are recommended most often because of their simplicity of administration. Tenecteplase is given as a single bolus over 5 seconds, and the reteplase is a double bolus 30 minutes apart. Administration time and drug errors are reduced compared with other fibrinolytics. Tenecteplase, like alteplase, has an intermediate risk of intracranial hemorrhage, has a higher rate of recanalization than other fibrinolytics, and it's rather expensive. Reteplase has the highest risk of intracranial hemorrhage, and the revascularization rate similar to that of tenecteplase, and it's expensive also. So streptokinase, it's the beginning of the area of fibrinolytics, currently not available in some countries, may induce allergic reactions, especially if it has been used previously and must be given by infusion over 30 to 60 minutes. However, it has a low incidence of intracerebral hemorrhage and is relatively inexpensive. Antistreplase, actually you can do this with give this streptokinase with dexamethasone, just to prevent allergic reactions. Antistreplase related to streptokinase, antistreplase is similarly allergenic and slightly more expensive, but can be given as a single bolus. Neither drug requires concomitant heparin use. For both, recanalization rate is lower than that with other plasminogen activators. Because of the possibility of allergic reactions, patients who previously received streptokinase or antistreplase are not given the drug again. Okay, alteplase is given even accelerated on or front-loaded dosage over 90 minutes. Alteplase with concomitant intravenous heparin improves patency, is non-allergenic and has a higher recanalization rate than other fibrinolytics. There are many absolute and relative contraindications to fibrinolytic therapy. In general, the presence of active bleeding or a condition whether bleeding would be life-threatening is an absolute contraindication. And about another drugs. Other drugs. Angiotensin converting enzyme inhibitor, so AC inhibitor, reduce mortality risk in patients with myocardial infarction, especially in those with anterior infarction, heart failure, or tachycardia. The greatest benefit occurs in the highest risk patients early during convalescence. AC inhibitors are given 24 hours after thrombolysis stabilization, and because of continued heparin beneficial effect, may be prescribed long-term AC inhibitors. Why not? Zartans, so angiotensin 2 receptor blockers, may be an effective alternative for patients who cannot tolerate AC inhibitors, for example, because of cough. Currently, they are not first-line treatment after myocardial infarction. Contraindications include hypertension, kidney failure, bilateral renal artery stenosis, and known allergy. Statins, AMG, HMG, CoA reductase inhibitors, so statins, have long been used for prevention of coronary artery disease and actually acute coronary syndrome, so myocardial infarction, but there is no increasing evidence that they have also short-term benefit. There is now, increasing evidence in that they have short-term benefits, such as stabilizing plaque, reversible endothelial dysfunction, decreasing thrombogenicity, and reducing inflammation. Yes, for short-term benefit, it's okay. Thus, all patients without contraindications, for example, statin-induced myopathy, liver dysfunction, to therapy should receive a statin at the maximal tolerated dose as early as possible following acute situation, acute ischemia, regardless of the serum lipid levels. PCSK inhibitor, for example, evolocumab, alirocumab, yes, Kumab, so Kumabs, evolocumabs and alirocumab, for patients not large LDL-C levels, used alone or a combination with other lipid-lowering therapies, for example, statins, ezetimibe, for the treatment of adults with primary hyperlipidemia, including familial hypercholesterolemia. Actually, that's all concerning drug therapy in myocardial infarction. So thank you. Thank you for your attention. Please do not forget to make your donations. Do your donations to our channel, because without your donations we cannot exist. If you want to see other lectures, so you must donate, my friends. So how to make your donations you can find in the description of this video in YouTube. So don't forget to subscribe and follow these channels, and God bless you. Bye.